Thank you all very much. What I want to do is mostly have a dialogue, so let me give you just a very brief overview and then let you take it where you want to. But let me start and say that I think that in a variety of ways, there are both a series of facts that are outside the current political dialogue, and there is a scale of change which is outside the current political dialogue. Now, among the facts I would emphasize are the fact that there will be 4 to 7 times as much new science over the next quarter century as there was in the last quarter century, and that probably 65% of that will come outside the United States. And that means that you're looking at a scale of continuous change that requires you to think about how do you build systems that are capable of evolving at that rate and are capable of absorbing and using new ideas and new solutions and new information at that rate. And it's particularly daunting when you realize that, as the Institute of Medicine pointed out, it takes up to 16 years for a new best practice to be commonly adopted. So if you're going to have wave after wave of breakthroughs, the odds are fairly high in a 16-year cycle you could die of whatever the problem was during the period we already knew how to fix it, but it hadn't gotten to you. And so it's a very interesting challenge, and it has implications for every aspect of our life. My guess is that the scale of scientific change we'll see will radically change how we think about energy, how we think about health, how we think about learning, how we think about the environment. At the Center for Health Transformation, we have 2 projects, one which has been launched that former Senator Bob Kerrey and I are co-chairing on Alzheimer's, and we have an Alzheimer's study group which has, among others, Justice Sandra Day O'Connor serving on it. And the goal of that group is to say, if you're going to have this scale of change, then how do you try to accelerate understanding what we could do with Alzheimer's, which is a challenge which will currently affects every 3rd person who's over 85. And for the baby boom generation is estimated to be $1.2 trillion cost for the federal government alone, not counting private costs, unless we do find some fairly significant breakthroughs. It turns out if you can postpone Alzheimer's onset by 5 years, you probably eliminate over half the cost of the disease. And so there are a variety of steps to be taken. The second project, which we will announce late this month, is it will be a bipartisan project to eliminate cancer as a cause of death. This was originally a proposal posted on the National Cancer Institute's webpage by Andy von Eschenbach when he was the head of the National Cancer Institute. He's now the Commissioner of Food and Drug Administration. And he felt very passionately that the scale of new science and new capability is so great that if we really focused on it, we could literally, within 15 years, eliminate cancer as a cause of death. And that is an extraordinary opportunity for us to make a very big difference. And so we're looking at that kind of breakthrough. So the first thing I want you to keep in mind is the scale of scientific change and the implications that has for every aspect of American society. The second thing I want you to keep in mind is that the world market is real. It's a fact, not a problem. What we do about it may be a problem, but the world market is real. And within that context, that China and India are real. And the reason that's important is it means that for the next 2 generations, we're going to be going through a continuous process of adjustment in order to be competitive enough to deal with China and India as economic competitors. Interestingly, I think the book which best covers this as a political topic is actually by Sarkozy. He wrote it before he ran for president of France, and it's called Testimony, and I recommend it to all of you. It's in English. And Sarkozy was dealing, as one of his major campaign problems, with the fact that the French had adopted a 35-hour work week and that it had made them literally non-competitive in the world market. And how do you campaign as a politician explaining to people that you have to work harder? And it's a very interesting book. He pulled it off quite successfully. His campaign is, I think, the most remarkable change-oriented campaign since Thatcher and Reagan in 1979, 1980, and is more complex because Thatcher had an enormous economic problem she was responding to, and Reagan had the collapse of the American economy under Carter. And so both Reagan and Thatcher had objective reality on their side. France is not in bad enough shape that you would have naturally expected the Sarkozy message to work, but he was able to make it into a very appealing message, and one in which he convinced the French people that unless they were prepared to be economically competitive, they would lose purchasing power And if they lost purchasing power, they would lose taxes. And if they lost taxes, they wouldn't be able to sustain the pension program and the health system. And so he literally was able to make the argument and win the case. And he won an election that no political scientist, I think, at the beginning of that campaign would have expected him to win. I say that as background because when you think about solving health challenges in the U.S., I think you have to understand that health, in addition to being a moral issue, is also an economic issue. And so you've got to find a solution which is sustainable in a competitive world market and in a way which enables us to confront the reality of constant pricing pressure from competitors like China and India. The third thing which I think is important to remember is that health is a moral issue. The first book I wrote on healthcare was called Saving Lives and Saving Money, in that order. Because I think part of what makes health different than, say, the economics of transportation is the degree to which health ultimately is about life and death, and it's about the quality of life, whether you can live independently or whether, in fact, you decay to a point where you have to live in a dependent state. And therefore, there's a moral power to dealing with health questions that you don't get in many of the issues that are normally dealt with by economics. And I think that it's very important, and in that context, we created the Center for Health Transformation, not the Center for Health Care Transformation, which is the fourth point I want to make. If you think first about health, and then you think about health care, you end up with a dramatically different model than if you start by dealing with health care. And this was really put to me strongly. I went about 5 years ago to Nestle's in Switzerland. Nestle is the largest food company in the world. They have a larger research budget than the Jet Propulsion Laboratory at Caltech. And I met with about 180 nutrition scientists. And at that time, the Center for Health Transformation had a model that was patient-centered. And they said that is exactly wrong. If you wait until people are patients, you've already lost the greatest opportunity to improve their lives. And they had a very simple three-part model. They said you have to affect attitude, activity, and nutrition. And if you can affect, for example, this may strike some of you as a little unusual, optimists are less likely to be sick than pessimists. Smiling is actually a pro-healthy phenomenon because it creates endorphins. So there's a whole zone of attitude that really matters. Activity really matters. Walking is dramatically better than sitting. This may seem like a small thing to some of you, it's not. And third, what you put in you really matters. So nutrition matters. And so they were working on a whole series of things. Excuse me. They convinced us to focus on the concept of the individual in a pre-patient environment, because if you can intervene, for example, with somebody who's pre-diabetic and you can get them to change their exercise pattern and their diet, you dramatically improve the likelihood that they will not become diabetic. That saves you all the cost implicit in their becoming diabetic. And even if you only postpone their diabetes by 15 years, you have all sorts of implications. Because in the ideal world, you would like people to live as long as possible, as healthily as possible, and that leads them to die inexpensively. And so it's actually to your advantage. If we could get everybody to live into their 90s, they would be less expensive, because the act of living into your 90s normally indicates a state of health which is relatively inexpensive. The people who are the most expensive have a chronic condition which degenerates, usually have 2 or 3 or 4 what are called, which are comorbidities, and the result is they become really expensive because they have long hospitalizations over a number of years, and so they accrue a very high cost. So it is actually in our interest as a country to optimize health, minimize illness, and as a byproduct, you save a lot of money. But the moral goal is to maximize your personal independence and maximize your length of life. Now, this is doubly fascinating to me because, just to give you some numbers, in 1900, the average lifespan in the United States was 46. Today, it's in the late 70s. A Japanese girl born last year, on average, will be 88. That means half of them will live to be over 88 years of age. No society in human history has tried to deal with this scale of lifespan, the complexities of it, the cost of it, the financing of it. It is a fascinating process. And because we have gradually shifted away from physical labor, people tend to be dramatically healthier much later. I had the great privilege of studying under Edwards Deming, the father of the quality movement, when he was 90. And he was teaching a 4-day, 10-hour-a-day course at 90 years of age. And he loved what he was doing. He passed away at 93. I also consulted with Peter Drucker when he was 89. And these guys were totally engaged. I on occasion, have opportunity to work with Henry Kissinger, who's now, I think, in his early 80s. And Henry flies all over the planet. It has the time. It's a totally different model of what it means to age from what it would have been in the past. Picasso painted, I think, until he was 93. And so you're going to see really dramatic changes as people live longer, live healthier, use their brain, and as they have expert systems to sustain them. Which is also going to change. One of the great opportunities in the near future is to move from a disabilities orientation to a capabilities orientation and figure out how we maximize the ability of every person who has challenges rather than how we sustain them with their disabilities, which is going to be a dramatic revolution in the quality of life for people who either are born with or who acquire physical and mental challenges. The last part of this I want to mention just as a broad sweeping overview is when you think on this scale, that you have to look at the technological opportunities that are very, very common outside of government, but seem almost mystical in government. And the easiest way to see this is if you go to YouTube and you look at a video, a 3.5-minute video we did called FedEx versus Federal Bureaucracy. But just to get the conversation started today, let me try this out in terms of your own lives. How many of you have a cell phone with a camera? It's almost tautological, right? That is, if you say cell phone, it almost certainly... Does anybody here have a cell phone without a camera? How old are they? I mean, can you still buy them without a camera? Are they cheap? I'm serious. Are they cheaper? $30, okay. I mean, I saw a Nokia that was $9.95, but it had no camera, it had a black and white screen, and only had one ringtone. And they told me at the store that I was at, this is about 5 months ago when I bought a new cell phone, they told me that they couldn't sell it because it was a sensorily impaired cell phone and nobody would buy it anymore. But now, do your cheap cell phones also only have one ring, or can you have multiple rings?
I only have one ring.
You only have one ring on yours? Do you feel like we ought to have maybe cell phone stamps for people who can't afford? I mean, I'm always interested in the politics of deprivation. Don't the rest of you have? Don't those of you who have cameras in your cell phones feel that you're looking here at the last stand of the old order of the people who walk around with a no cell phone, one ring? Do you have color screen or is it a black and white screen? Oh, okay, well, you're nibbling in the right direction. Get good grades. Maybe next year you can get a camera or something. Who knows? How many of you have ever gotten money out of an ATM outside the U.S.? Oh, pretty well-traveled group. Now, I want you to think about this experience for a second. You're in a foreign country. You walk up to an anonymous machine. It's available 24 hours a day, 7 days a week. You put in a plastic card. The screen lights up and asks what language you want. You push the one that you're most comfortable with. You punch in a 4-number code. It reaches out across 6 or 7 international borders, 7,506 miles. It finds your home bank. It verifies who you are, validates that you have money, changes it into the local currency at a slightly bad exchange rate, but better than, think about this, better than your hotel. It takes 11 seconds. And if I describe the real world, is that sort of what you've lived in? Is that about what you experienced? Now notice a couple characteristics here. First of all, you trusted the security system enough to open up your bank account over multiple international borders. Second, you trusted the expert system enough that you did not have a clue what the exchange rate was. I mean, I'm old enough. I remember you used to go in and you'd ask, and they still do it in banks and in hotels. They'll have this. You don't have any idea. Third, you have no idea how much money you just took out of your account. I mean, you're standing in Russia, you got 7,000 rubles, you don't know what the current exchange rate is, and all you know is you must still have money because they gave you cash. I mean, am I describing the real world? Now, the next time somebody talks to you about how complicated it is to have electronic health records, or how hard it is to have a guest worker program that has an accurate identity card that would have real-time verification, ask them what planet they're from, because they're not from Earth. Because both those exist right now, right? Now, last example of the gap between the world, this is why my new book, Real Change, was subtitled From the World That Fails to the World That Works. Here's my last example. How many of you have ever gone online to check where a package is at UPS or FedEx? Raise your hand. Okay, so this is not a theory, right? No, the reason I'm slowing you down here is, you know, sometimes you read the newspaper, Gingrich has a lot of interesting ideas, but after all, we have to be practical. Which usually means let's do something really stupid with the bureaucracy because we're too dumb to figure out something smart. So it is a practical fact that UPS and FedEx, in a system which has entrepreneurial behavior, market orientation, focuses on the customer, invest heavily in information technology, rewards achievement and punishes failure, UPS tracks 15 million packages a day. FedEx tracks 8 million packages a day, and they do it in a system designed so you can check your package for free. Am I still describing reality from your standpoint? That's the world that works. It's the world of Drucker, Deming, Juran, Womack. It's Toyota Production System, Lean Manufacturing, Six Sigma. It's all around you. You use it routinely. Now, it has real investments. UPS estimates that a UPS truck has more computing power than the Apollo landers that went to the moon. And that in the average doctor's office, when a UPS delivery person walks in, they double the amount of computing power in the doctor's office by what they're carrying on their belt. I mean, these are big investments. Now, over here is the world that fails. Take, for example, the Department of Homeland Security. Over here, we're tracking 23 million packages a day while they move. Over here, we can't find between 10 and 20 million people who are here illegally when they're sitting still. So one of my policy proposals has been to appropriate about $200 million and send a package to every person who's here illegally. When UPS and FedEx deliver them, we know exactly where they are. You pull them up on your computer. Now, that's obviously hyperbole, but let me give you a real example. Senior citizens abandoned in a nursing home in New Orleans during Katrina drowned in isolation because we had no system for identifying where they were. Now, had we sent them a $6 package, UPS could have told you where they were. But the city of New Orleans, the state of Louisiana, and the federal government didn't know they were there, didn't know to go get them, and they died, having been left behind by the nursing home staff that abandoned them. That's the difference in information flow. After Katrina, 1,100,000 people lost their paper records. The people at Truro, which is a facility in New Orleans that had electronic records, and the people at the VA had all their records. And there's one hospital on the Mississippi coast. Everybody else lost all their records. And the reaction of the federal government was not to finance an electronic health record to replace them, it was to go back and pay for the paper records again. Utterly, mindlessly stupid. I use the word stupid deliberately because we keep having these indirect political conversations, and nobody wants to just stand up and say, if you live in the middle of the 21st century and you're using a BlackBerry and you're using a cell phone and you're using a camera that's digital and you're using the internet and you have a laptop computer, and over here you're watching a bureaucracy that is paper-based, at some point you have to say, this is just dumb. It's not conservative, it's not liberal, it's just dumb, it's obsolete. It's obsolete at the school board level, it's obsolete at the state level, it's obsolete at the federal level. And one of the great challenges for your generation is going to be, can you, much like the progressive movement from 1896 to 1916, can you invent a wave of innovation that so fundamentally transforms government services that they move from the world that fails to the world that works? Now let me apply this to healthcare. It's not complicated, it's just hard. All information in healthcare should be electronic. Paper kills. We wrote a book, Dave Merritt, who's here with me, and I wrote a book called Paper Kills, because paper kills. We know that that's true. Paper prescriptions lead to 8,000 people a year dying. Now imagine in the aviation industry that 8,000 people a year were dying in airliners, and how big the demand for change would be. Piedmont Hospital in Atlanta, Georgia went to computer order entry by physicians and had a training program on quality. They reduced medication error by 93% the first year. Why isn't that the national standard? The gap between the hospitals in America with the fewest infections and the hospitals in America with the most infections is thousands of lives. One estimate is 50,000 people a year die from the disease the hospital gave them. Now, why do we tolerate that? We have a system of payment so messed up that when Virginia Madsen in Seattle, which is a medical group in Seattle, they sent 50 doctors to Japan to study the Toyota production system. They learned how to take waste out of the system. They designed a totally modern system. And the result was that they took 50% of the transactions out of their system, and they almost went broke because they weren't doing the things you charge for anymore. And the system currently is designed to maximize waste. And so you're really faced with huge underlying challenges in what we're going to have to do to dramatically modernize government and to dramatically modernize the health system. But the one place I want you to look at for just a minute, and then we're going to take questions, is I think slide 5 in the handout you've got it has 4 boxes. And I want to emphasize this because it's the biggest place where I disagree with all the presidential candidates. Politics in America and the news media in America all want to start with the box that's number 4, which is financing. I believe oh, you can actually put it up, you just put it up there, thanks. I believe you cannot solve these problems by starting with the financing. Because I think the current system will spend everything you decide that you want to spend on it. So if you tripled the health budget next year, they would absorb all the money. I think you have to actually start at the other end, and there's a secondary reason for that. I don't want to fund the health care system. I want to fund health. I want to maximize a fundamental transformation from a system that focuses on acute care to a system that starts with you as an individual, starting with prenatal care. Because we ought to have a healthy mother and healthy baby project, which then carries it. And by the way, that's the biggest single reason the U.S. does badly in international comparisons. The number of children who are born prematurely, the number of neonatal babies in the U.S. is a totally avoidable project if you fundamentally redesign the financing. But today we do not pay for adequate prenatal care, but we're prepared to pay $1 million to save the baby whose life should not have been in danger if there had been adequate prenatal care. It's a very fundamental problem in terms of why we look bad in international statistics, because we do such a bad job, particularly with the very poor. And now, that means intervention. You can't have a drug-addicted mother. You can't have an alcoholic mother. You have to actually have counseling. You have to actually intervene. Because if you don't, you're going to get fetal alcohol syndrome. The Dakota Indians have 100 times as much fetal alcohol syndrome as Asian Americans. That's 10,000%. That's a cultural problem with a health consequence. It's not a health problem. And so you're talking about if you really are serious about a healthy country, you're talking about very significant change. And the change has to start in the first box. What are the individual rights, responsibilities, and expectation of behavior? For example, if you have a child who's 12, 13, or 14 who's overweight, underexercised, and in danger of becoming a type 2 or adult onset diabetic at 15 or 16 years of age, do we have the right to suggest to you that that child needs to go on a diet and exercise? Now, you're going to show up the day that the child's sick enough. You're going to show up and say, we owe that child kidney dialysis the rest of their life. And we're going to find a way to pay for it, because we're not going to turn that child away. But do we have the right to intervene before they're so sick they need kidney dialysis to say, they're really 150 pounds overweight, and they really need to exercise, and you really have to have parental responsibility? These are very fundamental questions for this country to talk to itself about. I would argue you cannot afford a one-sided social contract in which everybody gets to be totally irresponsible and you're going to pay for them. You can't afford that system. But that requires really thinking through what are we doing different and how are we going to do it. Second, if you move towards individual rights and responsibilities, and by the way, Jeb Bush, when he was governor, actually rewarded people on Medicaid who were diabetic if they were compliant. So if they took care of themselves, they actually got a bonus at the end of the year because they were so much healthier that they saved money on emergency rooms and hospitalization. So there's a fundamentally different way of thinking about this problem. We have a project in Columbus, Georgia, where we are paying doctors $100 a year to help diabetics learn to take care of themselves. And as a result, we're saving about $350 a year on hospitalization and on emergency rooms. But it's a fundamentally different model. Paying people to stay healthy, helping them get educated to stay healthy, as opposed to waiting until they're so sick that there has to be a decisive, very large intervention. The second then becomes, how do you maximize cultural and societal patterns? Now, we've seen some of this. How many of you now use a seatbelt? Just raise your hand if you use seatbelts. That's entirely a cultural affectation. It's a decision we made over the last 50 years. When the Ford Motor Company first introduced seatbelts, they were a total failure. People didn't want to buy them on the grounds that people didn't want to think about their car being in a wreck. Today, probably somewhere 60 or 65% of the country uses seatbelts. So, by the way, other than not smoking, it is the single most effective thing you can do to stay healthy. Using a seatbelt is the most powerful single preventive thing you can do other than not smoking. How many of you are aware of the fact that if you drink too much, you shouldn't drive? I want you to think about this in a very serious way. You would not have known that in 1955. I mean, Mothers Against Drunk Driving have fundamentally changed the society. How many of you had no expectation that you would smoke when you came into this room? Think about it. I mean, did it even occur to you to even think about it? That's a radical change from 25 years ago. And you can tell that if you go to Europe or Asia, where the change has not occurred. So it is possible, in fact, to decide what is a healthy society like and how do you organize it. I would argue as a minor step in that direction that in order to deal with teenage obesity and diabetes, we ought to have physical education for 5 days a week for K through 12 as an integral part of the society to get people back in the habit of exercise. But you can argue about which ones you want. But unless you think first about the individual and second about reinforcing the individual, you cannot have a health-oriented system. The third area is really looking at the current health delivery system. It is a very, very inefficient system. My guess is, having looked at this now pretty consistently for the last 9 years, that if you were to have the same level of efficiency and productivity that you get at the Toyota production system, or you get at the Ritz-Carlton, or you get at any of the modern high-tempo service-oriented systems, you would probably take 40% of the cost of healthcare. There's that much waste, there's that much unnecessary activity, in addition to which we have designed it so badly that there's an amazing amount of fraud. The New York Times estimated 2 years ago that in New York State, 10% of all Medicaid spending is fraud. Not waste and abuse, fraud. For example, a dentist who filed 982 procedures a day. A dental office in Brooklyn that had somebody who stood out front and said, if you'll give us your Medicaid card for 30 seconds, we will give you a free DVD player. This is just pure fraud. And the system is so incompetent that we don't catch them. Because it's not electronic, it's paper-based, there's no expert system analysis, and so this stuff goes on and on. That's, by the way, for New York State alone, that's $4.4 billion a year in Medicaid fraud. So when you start looking at the scale of how would you pay for getting to 100% insurance, if you had a system which had personal responsibility, cultural reinforcement, and was efficient, you'd have far more money than you need to get to 100% insurance for the whole country. I'll give you one other example. In South Florida, in the entire country a couple years ago, we were spending $1.1 billion on HIV/AIDS therapy in 3,297 counties and $2.5 billion in 3 counties in South Florida. There was an FBI task force formed. At one point, on one particular day, they raided 17 facilities that did not exist. 5 of them were pizza parlors who had simply gone to the local printing office, printed up forms that said they were an HIV therapy system, sent in the bills, and the federal government sent them checks. And the technique was, when the federal government finally figured out you weren't real, you had nothing to lose. You know, you closed your post office box, and you went down the street and you opened a new one. The estimate is that there's over $1 billion a year in pure fraud in HIV/AIDS therapy in South Florida. I mean, so you've got to look at these big, cumbersome, inefficient systems. The last step is, I think, is financing. My personal belief is I think our goal should be every American is inside the system, but the system should be a 300 million payer system, not a single payer system. I think it's very important for each of you to be a customer and not be a client of a bureaucracy. And I would voucherize Medicaid to enable people to buy insurance. I would also have a very large tax credit for the working poor and for small businesses. And I would require people who are well off to either buy insurance or to post a bond. But I do not think we should allow people who are well off to take a free rider approach that says, I'd rather buy a second car or buy a second home or go on a nice vacation. I think I'll just skip health insurance this year. And then they show up at the emergency room after their motorcycle accident or after they're in a car wreck, and they're going to get treated. Because the truth is, we're not going to allow anybody to die. And so people are today, there's a substantial number of people today who are deliberately not buying insurance on the grounds that probably nothing will happen, and if it does, my neighbors will pay for it. I think that's just irresponsible, and I don't think we as a society have an obligation to tolerate that. But I'm willing to meet the libertarian argument and say, fine, if you'll post a bond, you don't have to buy insurance. But I do want you to prove you're prepared to pay for your obligations if something happens to you. I don't think it's fair for people who are well off to try to simply game the system. Anyway, that's a very sweeping overview, and I thought we'd just toss it wide open and we'll go where you want to take it. So I gather there are microphones up here. I assume that's for a purpose. So any of you who'd like to ask questions or make a comment, feel free.
We do want people to use the microphones if we can. We are taping it, but feel free on any issue. Let's stay on health care for a while, and if we can.
But now just go to the microphone. Just walk up to the mics and we'll let you ask. Go ahead.
One of your main tenets for improving the healthcare system is that we should focus more on preventative healthcare. How big of a factor do you think the skewed perspectives of preventative healthcare, and by that I mean, drug companies who lose out on revenue because, a sick person is not buying their drugs and is instead healthy. How much of a factor do you think that those skewed incentives has on preventing, the reforming of the healthcare system?
Well, I think that a preventive and wellness system is probably good for the drug companies, not bad for them. I mean, if of the people who should currently be taking preventive drugs, fewer than 50% are compliant. And I've argued for a long time that we'd be better off to find a way for everybody to be compliant at a lower cost, and the drug companies would make more money on aggregate. They'd make less money per individual pill. I favor going to a Travelocity model of buying drugs where you could see the price of every single drug that's available, and you can see what your choices are if you're in a class of drugs where there are 10 or 12 different drugs available. You can see which ones you'd pay for, how much you'd pay, and what the indications are of which ones are useful and why. I do think you ought to have the competitive information, and you and your pharmacist or you and your doctor ought to be able to choose out of that class of drugs. But I also think that there's a lot of stuff you can do that doesn't take any drug. Disciplining yourself to walk every day doesn't cost very much. And there are a variety of things people need to do regularly as a preventive device that's very, very helpful that doesn't cost anything. Yes, ma'am.
Hi. Two questions, if I could. One is, I know that a lot of people have been trying to work on this issue of electronic medical records. I've been out of D.C. for a little while now, but I was wondering if you could update us on where we are with trying to standardize that system and get the interoperability, taken care of and some of those questions. Because I think that it seems as though that seems to be a well-agreed thing that we need, and I know there are people working hard on it. And second, in a similar vein, there are a lot of problems in healthcare. You've just mentioned many of them. I also know that, again, there are a lot of people who are working hard on trying to, solve all of these problems. I'm wondering if you could give us just a couple of examples of places that you think are innovative, doing innovative things or good models for the future for the country as a whole. Thanks.
Yeah, those are both good questions. On electronic health records, let me say first of all that two of my favorite examples. One is Allscripts, which has a North Fulton Family Medicine Clinic, which actually went to a workflow-oriented electronic health record. And this is a very important part of this. If you're going to have doctors use these, they have to fit the way the doctor works. Doctors are not going to change how they work in order to fit an electronic health record. But if you can get the electronic health record designed so it actually fits the way the doctor works, they are amazingly efficient. And at the North Fulton Family Medicine Clinic, they were very shocked in 1998 to discover that instead of costing them money, the electronic health record was saving them an average of $33 per patient visit. They were stunned how much time they were spending going and looking for paper records and waiting around and trying to get the information correct. And they all of a sudden had a dramatically more effective system. They've grown from 4 doctors to 10. They're in 4 different physical locations. They're happy to testify to anybody who'll talk to them. They can handle more patients every day with fewer clerical staff. And because the workflow takes care of all the information during the patient visit, they do no transcribing in the evening, so they leave the office at 5:15 having gotten everything done. They think it is an absolute winner, and they would recommend going to an electronic health record to any doctor who asks them. And they think it doesn't cost money, it actually saves money, and is remarkably effective. The second place I would cite is the Inland Northwest Health System in Spokane, Washington, which started as a startup by the 4 hospitals in Spokane that then built a freestanding subsidiary that originally began as an air ambulance for the Northwest and then migrated into the electronic information space. They now have a whole series of clients so that, for example, if you're a very small rural hospital in eastern Washington and you really don't have a full-time pharmacist, you can have a nurse who is assigned to the pharmacy area, and they can actually communicate electronically with the pharmacist in Spokane, and they can then open up the safe and allow them to get the correct medicine. It's a very sophisticated system. They're now in King County, which is Seattle, and they're now in Los Angeles with the Providence Hospital System, where they have 3 hospitals. And they are probably the most interesting full-blown use of electronic information in terms of knitting together hospitals. There are a number of other places that have first-class systems. Mayo has a very powerful system that works very, very well. And there are a lot of other places that are developing in the right direction. The interoperability, I think, is much less of a problem than people think it is. It's a political problem. It's not a technical problem. MISIS, which is a fairly substantial provider of electronic health information for doctors, has put all of their interoperability information as open source, so that anybody in the world who wants to work on the code can work on code. And their estimate is that by doing that, if all the other major providers would do that, you would have thousands of people writing code around the planet who would rapidly create interoperability as a practical matter. I've suggested that an alternative strategy is to get the 7 or 8 biggest companies who have most of the electronic health records in the country, have their CEOs in the room, and the first week that they're in the meeting, they get 3 meals. The second week, they get 2 meals. Sometime late the second week or early the third week, they would announce an agreement on interoperability, and it would come together. I don't know how many of you have ever worked at a company where we recently had some problems with our server in the companies that I operate. And I was feeling bad until I was trying to communicate with a guy in California who's made huge amounts of money out of information technology, whose own company had lost their connectivity for 4 straight days. Part of what you have to remember is all this stuff is really complicated. And so even when you start talking about it being easy, it's doable, but it's probably going to take a 5 to 10 year migration. But we should be able to establish as the standard that the federal government is only going to pay for electronically filed information, and that the federal government is going to insist over a period of 3 to 5 years that people migrate to open source models that enable them to have connectivity with each other. And I think the rest will then fall in place pretty rapidly. Yes, ma'am.
Hi. We know that in this country and lots of other places, there's sort of widely disparate health outcomes by income and by socioeconomic status. And I'm wondering, sort of looking at this model where we don't start with financing, which I think makes a lot of sense, what are the policy implications for that in terms of individual rights and responsibilities, in terms of maximizing cultural and societal patterns? What does what we know about how income affects health, or at least correlates with health, change how we think about that?
Yeah, that's a good question. Let me, by the way, I didn't answer the second question I was asked earlier, which was on good places to look. I think the most interesting developments in health policy in the country right now are in Louisiana, and I would strongly urge you to look at what Bobby Jindal's doing. He is a brilliant young governor, a brand new governor of Louisiana. He's only been in office since January. He's had 2 very good special sessions of the legislature already, has passed much stronger legislation than people thought possible. He was, at 24, the Medicaid director for the state of Louisiana. He then worked for Senator Breaux and Congressman Thomas on the Medicare Commission in his mid-20s. He then became the Assistant Secretary of Health. He went home 4 years ago, ran for governor and lost. He then won a congressional seat, and now at 37 he ended up as governor. He's a phenomenal person, and the first person of Indian American descent to become a governor of a state, and I think probably a future presidential candidate. And he's really worth looking at because he really knows what he's doing. He brought in Alan Levine, who was Jeb Bush's director of health in Florida, and Alan is a very aggressive entrepreneurial personality. And between the two of them, they're going to do an immense amount, focusing on the right to know, on transparency, on providing information on the internet about price and quality. And I think if you watch them, and if you Google either Alan Levine or Bobby Jindal, you'll see an amazing amount of really interesting health policy being developed. And I think it's in some ways, the most interesting place in the country right now. I want to raise this question because I think it's a very important question about health outcomes. And I want to make an assertion that'll be interesting for some of you to maybe follow up and we can have a discussion. I believe we are suffering from bad culture and bad government. And I believe we don't know how to talk about it, and we don't know how to deal with it. You show me a very poor neighborhood, and I'll show you a neighborhood which has deep cultural problems, as a result of which they have economic and health problems. But the culture comes first. And this is a very hard problem. And people don't want to deal with it. And they don't want to talk about it. I'll give you an example. I mean, there are 2 obvious examples, one of which would be a great study, which I'd love to collaborate with some of you if you'd like to do it. The first one's is further away, and that's Detroit. In 1950, Detroit had 1,800,000 people, and they had the highest per capita income in the United States. Today, Detroit has less than 900,000 people. They're using less than half the housing stock in the city. They're the first American city to drop below 1 million. And they've dropped from first to 62nd in per capita income. And in the last 3 years, they had the highest out-migration of any major city in the United States. 37,000 people left in the last 3 years. And nobody wants to study it. Nobody wants to say, gosh, what's going wrong here? And it's not the auto industry. Grand Rapids is on the other side of Michigan. Grand Rapids has a building boom underway. It is really bad government compounded by really bad culture. And the result is nobody who's rational will invest, which means that the housing prices have collapsed. So you've cheated. I mean, it looks like an economic problem because you've cheated every person who bought a house in Detroit because they've been going steadily downhill. It's a very interesting question. Now, the same case, and this is what I'd love to see a study, maybe somebody here at Princeton, is go look at Camden. Camden's across the river from Philadelphia. Philadelphia in the last 20 years has had a renaissance. Why didn't it cross the river? How has Camden managed to avoid it? Because this gets, in a sense, to the heart of your question. If you have a neighborhood or a community which is very poor, and you go into that neighborhood and you said, I'd really like to talk to you about preventive health, and you're dealing with young people who believe they're going to be shot before they're 20, or they're going to end up in jail, you have a really hard sell. And then you go and you talk to a young girl who gets pregnant at 13 in a neighborhood where she's using either alcohol or drugs or both, and you're trying to talk to her about fetal alcohol syndrome. You have a really hard problem. Or you go on a Native American reservation in the Dakotas where there's no private property rights, there's no sense of a future. They have the highest suicide rate in the country. They have a huge fetal alcohol syndrome problem. They look like they're health problems, but they're not health problems. They're cultural problems. These are health manifestations of a cultural problem. And I think we're going to have a very painful and very serious conversation as a country about to what degree are we prepared to change things. Gallup does a world poll. They're in 125 countries with 1,000 sample, and they ask all sorts of questions, among which are a series of questions about being angry. They've now announced with Healthways that they're going to do a well-being poll of the United States. And starting on January 1st, they've been taking 1,000 samples a day. So that at the end of this year, they'll have 365,000 samples. And they ask a bunch of interesting questions. One of the questions they ask is, were you really angry yesterday? The 100 wealthiest counties in the United States resemble Sweden. The 100 poorest counties in the United States resemble Sierra Leone. And the question you have to ask yourself is the wealth a function of having money, or is having money a function of a culture of wealth? And if the wealth is the indicator, let's try an experiment, take 1,000 people, give them each enough money and see what happens to it. If the culture is the reason, then let's find out what happens to people who leave the culture of poverty and enter the culture of being successful. A very fundamental question about which comes first and how do you do it. But I would argue if you're serious about a healthy country, if you really want to save lives and save money, we're going to face greater internal cultural change and more internal cultural arguments in the next 20 years than we've had other than the civil rights fight over segregation at any point in the last 60. And I think it's absolutely unavoidable if you're serious about saving children and you're serious about trying to have a healthy country. Yes, sir.
You've said that you're in favor, obviously, of preventative health measures, but you also said that you're against the Democrats' proposals for mandating health care. How do you respond to the argument that if you had people who are currently uninsured, under insurance, then they would seek preventative health care, going to more regular doctor's appointments rather than going to the emergency room?
Look, what I said was I am for everybody being insured. I'm for 100% insurance coverage. But I would like you buying the insurance coverage. I'm against a single-payer, bureaucratically run system. Because I think if you just look at the New York State Medicaid program, which has 10% fraud, why would you think the federal government can run a system like that? I mean, what possible reason do you have for believing they'd have a clue what was going on? And so I am very much for us providing the resources for every single American to be part of the system. I am for fundamentally reforming the insurance system until every person can buy into group insurance, because I think it's irrational to have an individual market, because the risk pools make no sense at all. But I think in that context, I'd rather have you be able to buy the insurance, but I'd like to make sure you have the money to buy the insurance and that the insurance is available to be purchased. And my guess is that part of what you said is right. You would have an increased interest in prevention and wellness if you had access to it. Although if you look around the country, it's amazing how many places there are you can get access if you want to. Again, it's partly a question of emphasizing it and trying to make it a habit. I would also tell you, there are lots of places that have very high coverage of insurance for people who don't engage in wellness. And I met just as recently as yesterday with companies that are trying, or the day before yesterday, with companies that are trying to, very, very expensive insurance programs where they're trying to figure out how do they get their employees in the habit of prevention and wellness. Because we are not used to the idea, starting in 1943, when we went to third-party payment models and the employer picked up the model. We have built a health system where the average person doesn't think they're responsible. And so they don't have the habit of taking care of themselves. They don't have the habit of thinking about prevention. It's a very significant challenge. Yes, ma'am.
Can you address the malpractice crisis and the consequent use of defensive medicine? And
Sure.
also, can you talk about physician extenders?
Two very different questions. Let me start with malpractice. I think we have a real problem not just with doctors but with the entire system, because beginning in the mid-1960s we redefined the nature of equity of lawsuits, and we created basically a happy hunting ground for trial lawyers. And we've now created a commercial business of suing people, which is run by fairly ruthless people who are eager to be able to buy a baseball team and a G5, and are quite happy to sue anybody. And we have what I think is a pathological model of TV advertising that basically, all of you have seen these ads, that basically say, hi, don't you know somebody with money? Why don't you drop by for a free consultation? Let's see if we can't mug them for at least a little bit. I mean, think about the underlying cultural nature of these ads. They are fundamentally antithetical to a free society. And I think it's a very dangerous model. But in addition, you'll notice several of the most famous trial lawyers recently have pled guilty or been convicted of felonies. And I think it's because we're not yet prepared to talk about the degree to which the litigation system has been corrupted by the pursuit of money. And it's a problem of the whole litigation system. Now let's come down and talk about malpractice for doctors. The two places that have had the most successful malpractice reform are Texas, where Dr. John Gill, who works with us at the center, helped lead a 7-year fight, and Missouri, where Governor Blunt passed very, very strong malpractice reform. The Texas story is very interesting. The doctors and their allies in the business community finally decided they distrusted the Texas Supreme Court so badly that they wrote a constitutional amendment and wrote it into the Texas Constitution and passed it in a referendum. And it fundamentally changed the cost of malpractice in Texas so decisively that Texas has had an average of 4,000 doctors a year moving into Texas. So that today in the Valley, there are areas that had no doctor for 20 years that now have doctors practicing once again. I was in Oklahoma recently, and they were complaining because they had lost doctors to Texas, and Texas trial lawyers were moving into Oklahoma. So, so they said they had the worst of both worlds developing now, and they really weren't quite sure what to do about it. But I think tort reform or litigation reform is essentially a straight power struggle. The trial lawyers want the money. The rest of the country doesn't want to give them the money. The trial lawyers want the money more intensely than most of the rest of the country doesn't want to give it to them. And so you have to fight that out. But clearly, when we have driven out in Las Vegas, for example, there are no more OBGYNs available for people who get pregnant. I mean, there is a point here where the average person says, I would rather have a doctor than a lawyer. And I think you will see us gradually win the fight, but it's a huge fight because of the amount of money the trial lawyers have and the amount they're willing to spend in politics in order to sustain their current advantage position. On physician extenders, as a general principle, I am very much in favor of them. I think that you live in an age when we have all sorts of capabilities to extend the ability to get things done. In almost every other aspect of life, you have highly specialized people who focus only on the complex things they do brilliantly, and you try to externalize as many other things as you can to have other people help you. If you look at a modern operating room, as Dr. Frist will tell you, he had all sorts of people who made him possible. If he wasn't extended by the entire operating team, the intensive care team, the prep team, the radiology team, he couldn't have functioned. So we understand that concept there. We don't understand it in regular doctors' offices and in places outside of the operating room.
So regardless of how well people take care of themselves, it's reasonable to imagine at some point they'll end up in the hospital for one reason or another. What, in your ideal conception of the American healthcare system, is the role for privatized hospitals?
For privatized hospitals? They're generally more efficient, more aggressive, and use technology faster than public hospitals. I mean, so I would say if you look around the country and measure the facilities, that you could make a pretty good argument that you probably get more for your dollar when you look at the best of the privatized hospitals. So that'd be my bias.
Certainly one problem is malpractice, but one could say that another problem with standards, especially on the doctor side of medicine, is the current system of insurance. In that, in often non-metropolitan areas, doctors find themselves in scenarios where they often cannot set their own rates for certain procedures because all of their patients participate in certain insurance programs. And so I guess I would ask you is, in your envisioned system, how would the government set rates for doctors? Would there be any type of negotiation? And how would they ensure that, I guess, the best doctors are, going to certain geographical regions instead of there being shortages because of rate cuts?
Well, look, I mean, the rate cuts are all political. I'm against the government setting prices. I think in the long run, this is a core argument we haven't had in healthcare for 30 years. In the long run, I think markets are much more efficient distributors of talent than bureaucracies are. And I think when you look at the Dartmouth Health Atlas, and you realize that Iowa, Wisconsin, and Minnesota have better outcomes at lower costs than northern New Jersey or southern Florida, then you have to ask yourself as a taxpayer, why are you paying more for a worse outcome? Now, nobody wants to ask this because it's politically so sensitive. But I think it's exactly the right question. I'll give you an example. I don't know how many of you noticed the other year, 2 years ago, when Medicare Part D came in, and there were complaints about too many choices for senior citizens. Did any of you notice this? Do you know what I'm referring to, where people were complaining, the politicians were saying, you know, they've designed this so that there are too many choices for senior citizens to make? Does anybody remember what I'm talking about in Medicare Part D? He does, because he was in the middle of it. Raise your hand if you remember this argument, because I want to make a case here. I think this is very central to the question you're asking, but from a different angle. I happened to read one of these articles while I was on a cruise ship. Now, how many of you have ever been on a cruise? I want to say, okay, pretty well-traveled group here, right? So you'll understand what I'm referring to. I'm on this cruise ship, and it suddenly hit me. I don't know if you've ever thought about this. There are many cruise ships. They leave many ports. They go many places. When you stop somewhere, you could do many things when you're ashore. They have menus that are very complex. They have many kinds of drinks in the bar. They offer many types of entertainment. They have different cabins that cost different prices based on the quality of the cabin, the size of the cabin, the view you get, and when you bought it. You with me so far? I suddenly realized, it came to me in a blinding flash, that cruise lines are a conspiracy to rip off senior citizens by offering so many choices that they get confused. And so I began to design a new program, which I'd like you all to help me. And this, again, would be a great, if one of the classes here, maybe in economics, could help me design this, or in public policy. I began to work on a program I call MediCruise. And the way MediCruise would work is we would hire about 15 people away from the Center for Medicare and Medicaid Services. We'd give them an office in Baltimore right next to CMS. And they would scan the planet. And they would pick the 3 best cruises, which we would call Federal Cruise A, Federal Cruise B, and Federal Cruise C. Then the federal government would negotiate with the cruise lines to redesign the ships so that every room was of exactly equal value. So if you got a really high room with a really good view, it would be very tiny. But if you were down at the very bottom of the ship with no view, you'd be the size of a condominium. Then the federal government would approve the food program, so it was totally healthy. And they'd approve appropriate beverages. And the federal government would review the entertainment to make sure that no senior citizen would die of too much excitement. And then, as a final act of guaranteeing that seniors would not get ripped off, we would make it illegal for seniors to spend any of their own money on a cruise line other than the 3 federal cruises. Now, do any of you think this is a rational plan? I just described Medicare. That's the Medicare program. The Medicare program is more nationalized and has less choice than the British National Health Service, which allows contracting out. The Medicare does not allow contracting out. Bill Gates' father cannot pay extra in Medicare. There can be no choice. Everybody's trapped at exactly the same level. I mean, it's an irrational program in its current form. And AARP will be very excited that I said that. But I would challenge AARP to propose MediCruise and then have a debate with their own members as to whether or not they should be denied the right to spend their own money. Because that's what we say today. And it's wrong. And the result is, if you're a doctor in rural Iowa, you get ripped off. But if you're a doctor in Miami or if you're a doctor in northern New Jersey, you get all the extra money. And then we say, gosh, why did the doctors leave rural Iowa? Because you have a politically designed system which overfavors urban areas and rips off poor rural areas. And then we get surprised that doctors are smart enough to figure out not to go where they don't get paid. And it's really wrong because, in fact, you could argue the best care in America is given in the upper Midwest, and it is the most unfavorable economic situation in the country. It's fundamentally wrong, and it's fundamentally political. Yes, sir.
You talked about how inefficiency and fraud add to the cost of health care. I know that in New York, private health care insurance, there's so many requirements that you have to buy the Cadillac of plans. How much is this kind of state regulation contributing to the cost, and how would you go about convincing state legislatures to reduce the requirements they have?
Look, and until you understand, and this has been a gradual process on my part, and it's why I founded an organization called American Solutions. Until you come to understand how deeply state capitals, particularly Trenton, Albany, Sacramento, Massachusetts, how deeply they are dominated by special interest, you can't appreciate how these things are designed. I mean, New York is an artificially expensive health system propped up by special interest groups, largely dominated by one union on behalf of that union's members. And it's a very major problem in American public policy today. Because you then talk about how do you solve the problem, and since you can't reform the system, you end up saying, well, we better raise taxes to pay even more money into a system that's fundamentally deeply flawed. And I think this is one of the most important challenges in American self-government today. Yes, sir.
Most Americans right now get their insurance from their jobs, and these jobs provide a very limited selection of insurance plans to the American workers. Do you think that constitutes a problem of lack of competition in the market of insurances? Is it, to have many monopolies rather than have this?
Yeah, I think the question of how many big insurance companies there are is a challenge. It's interesting in Switzerland, which has a fundamentally different model, but which voted 71% last year against going to a national health insurance system. In the Swiss model, you're required to get health insurance, but there are something like 750 insurance companies in a country of 9 million. There are essentially only a handful of big insurance companies in the U.S. today. And that's largely a product, I think, of the way the regulatory system has evolved. The modern regulatory system makes it extraordinarily hard to invent new insurance companies. But in fact, what you'd like to have is an explosion of new insurance companies. And by the way, when a really exciting, really dynamic new insurance company grows up, about the time it gets to be just big enough to prove that it's really good, it gets bought by one of the really big systems and promptly loses all of its energy. I mean, it's a very interesting problem, and I think that finding a way to have not just more insurance companies, but also finding a way to have direct purchasing. I mean, if you're a big company and you're basically self-insured, so the insurance company's not providing insurance, they're just providing administrative overhead. You may be better off to find local doctors and local hospitals and try to contract directly and basically eliminate the insurance intermediary and see if you can get a better deal. And I think you'll see these kind of experiments developing over the next few years because the declining cost of information flow allows you to use information technology so you can have very inexpensive contracting at levels you couldn't have had 20 years ago. And 20 years ago, these big insurance companies grew up because they handled all the paperwork for the companies. But the paperwork is less and less relevant, and your ability to handle this information electronically is allowing for a dramatic decentralization and for much smaller sized institutions to be very competitive. I'd commend to you a book called An Army of Davids. It's a really good study of the degree to which you're beginning to get much smaller units capable of competing because of the inexpensive cost of information flow. But let me just close with this thought for all of you. I think you are entering a period that is going to be stunningly exciting. I think that the continued explosion of Moore's Law, which says that the amount of computing you can buy per dollar doubles every 16 months, is going to continue to be true. I think the breakthroughs in science are going to make even more things possible. I think you're going to see the old order, the world that doesn't work, more and more obviously incompetent. And I think as a result, we're going to enter a period of change comparable to the progressive movement from 1896 to 1916. And I suspect that your generation has an opportunity to invent an information age, very, very modern American government at every level, from local government and school board to the county government to the state government to the federal government. And as a result, I think we will probably 20 years from now be a dramatically more aggressive and entrepreneurial society that has much greater capacity to innovate and to use new ideas and new approaches. And as a result, I don't see any reason why we can't set as our goal maximizing the health of the American people of all backgrounds in every neighborhood and finding a mechanism to enable every single American to be covered by insurance so that everybody is part of a system in which we try to help you live as long as possible and as healthily as possible and have the highest possible quality of life and do so at the lowest possible cost. I think that ought to be our goals, and I think for your generation as you graduate and go out into the world, I hope you'll take seriously as a citizen being the kind of social inventor that helps us create that kind of breakthrough. And I think it could be a very, very exciting and dynamic 2 or 3 decades. Thank you all very, very much.